Hello, this is Nick Rainey. I'm a student at Rocky Mountain University of Health Professions. I'm part of the Clinical Excellence Network, doing a report on a case I had of an athlete that wanted to return to playing sports. He was a 15-year-old male, a right-handed quarterback and baseball player, and was examined April 16, 2013 with a referral diagnosis of L5 pars defect. His chief complaint or his chief goal is to return to playing football and baseball. He first started feeling symptoms April 2012. He had an Oswestry Disability Index score of 0. While this was a little surprising because it has caused him to not be able to do things he would typically do, none of the questions on there were indicative of anything it wasn't able to, that it was limiting him. I've predicted number of visits to be 12. I don't think that this obviously is not to decrease his disability index score, but it is to get him back to help him with his chief complaint or his chief goal. I anticipate this will take about 56 days or 8 weeks. His chief complaint is that the back pain, lower back pain there, occurs mainly, with the activity. And right now he's not feeling any pain and hasn't for a little while, but later last year it was very debilitating. And he's never felt any numbness or tingling. There's a lot of structures. If you want to pause it to look over the structures that I'll want to be considering in my physical examination. However, he did come in with a diagnosis of a specific anatomical defect that I do think is important. Whereas often I don't feel that anatomical structure is as important when determining diagnosis, but in this case I definitely did. So my primary and secondary hypothesis both have the L5 defect in there, but the treatment-based classifications I'm really looking at is stabilization and specific exercise. This pain was aggravated originally by weighted back squats and then eventually twisting to the left. His easing factors were just stopping that. As time progressed, though, the level of pain that it went down to was never a 0, unfortunately. It should be noted that he hasn't had any of his pains recently. There isn't any sleep or 24-hour pattern. Again, his symptoms have been about a year, but that's when they started. We haven't had them in the last 2-3 months. The mechanism of injury really felt like they talked about a lot, him and his dad, that back squatting was one that they kept hitting, they kept talking about. That was with the football team. The pain progressively got worse from April till August until he felt so stiff it even affected ambulation each day. He decreased his weightlifting during football season, so his pain got a little bit better, even though he was playing football. Once he started lifting again after football season more, pain started rising. They went to get an x-ray. That was negative. They were a little bit befuddled of what was going on. Went back in January because the pain was still there. Had another x-ray and MRI. They were both positive for a unilateral grade 2 spondylolisthesis on L5. And he has not participated in any physical activity since that time. Nothing else significant in his history. Nothing significant in medical history, no red flags, but a significant yellow flag that will affect a lot that I do, at least in this examination and then progression. He hasn't done any physical activity for 3 months, even though he hasn't had any pain. And he did have that imaging. He's not taking any medications now. I really struggled with finding an asterisk sign. Typically, I like to find an asterisk sign, something I can see how they're doing after each visit. But even retrospectively, I don't know what I would have chosen. My goal was I didn't want to be causing pain. I didn't want the first time he felt pain in a few months was after he started working with me. And so there wasn't anything else I could figure out that I could assess each time. Still, my hypotheses are musculoskeletal. I didn't have anything non-musculoskeletal I really wanted to rule out. So I'm still at stabilization and specific exercise. I felt like his condition is very severe. Kind of interesting. Normally we consider severity, on a 0 to 10 NPRS, at least above 7 or so. And he hasn't had any pain, 2 or 3 months. But it is very disabling partly because of fear, partly because there is, that anatomical defect that, was causing him a lot of pain. He's had to let that heal. But it did keep him out of baseball season, and has a little bit of trepidation of resuming again. His irritability, however, is low. He hasn't had any pain in 2 or 3 months. I'm sure we could cause it if, with trying, but it seems to be pretty low irritability since he hasn't had any pain in 2 months. I do think it's musculoskeletal. I think that the articularis defect is what was causing the pain, and now that that has had time to heal while it isn't together again, he's not having any of that pain. I don't think it's in a stage of healing. I think it has healed. And then we could reproduce it. What used to be very stable, but we're not attempting to reproduce it today. So the physical examination, the first one is more rule out the directional preference, see if anything changes with any of active range of motion and with his lumbar movement. Also, we're going to do exercises that challenge the core and hip coordination, endurance, and strength. It's not particularly part of the CPR for stabilization, but it is part of the predisposing factors I want to look at, see what I see there. And then straight leg raise, see if that's over 90. See if there's any aberrant movement when he's standing up erect after he's been flexed. I don't anticipate causing any pain with the pit test. I'm not going to really push to find out because, I don't want to be the first one to cause him any pain in 2 or 3 months when on his first visit, especially with me. And he is under 39, so he already fits at least one of those I know for the CPR. Nothing I'm going to defer. It's pretty straightforward. I should be able to figure out which one I'm going to go with, my hypotheses this first day. The precautions are contraindication. I don't want to put him into loaded axial extension. I really don't think it's going to cause him pain, but he's a little bit scared of that position. I don't and plan on doing somewhat of a graded exercise program and going right into that grade initially. I don't think it's the correct thing to do. Nothing significant with this postural observation. No asterisk sign of this functional movement analysis. Nothing caused pain. I did go through the hips and the knees and the ankles. All the range of motion was within normal limits, and all non-contractile soft tissues seemed to be intact. I did do a quick sensory and reflex screen, and all that was within normal limits. And again, lumbar, I did lumbar active range of motion. I did overpressure and all ranges except to extension. We didn't do that because he has a bit of a fear there, and I don't want to be the first one to cause him any pain. Palpation didn't elicit anything, nothing significant in the spinal segments, no joint restrictions. Manual muscle testing, he was equal bilaterally. Hip flexion and knee extension were both 5 out of 5, but hip abduction and hip extension were 4+ out of 5. And his hip abduction there was significant TFL activation as evidenced by hip flexion during the test. This is significant. It may not be for all people in population, but to return to sport, especially when he's had issue, just right above those regions. I want to make sure these are good and strong and can do even more so than maybe what a typical athlete would need. Muscle length testing, straight leg raise was over 90 degrees, so that gives me my second item for the CPR. And I didn't perform any other specific special tests. So for motor control, I did 3 main ones. I did bird dogs. I looked to see what happened in the lumbar spine with arm raise and also with hip extension. Nothing happened with arm raise, but with hip extension, we did get an increase in lordosis in his lumbar spine when he extended his hip. Unilateral bridge, I had him go up with both legs, and then he would extend his knees. So that'd be one leg was closed kinetic chain. And I observed difficulty, and there's transverse plane movement starting about 30 seconds. In side plank, I attempted to have his ankles stacked and then his forearm on the ground, but he's unable to perform this with his upper body perpendicular to the floor. So my primary hypothesis is stabilization. He had 2 items for the CPR, which really doesn't give me very good likelihood ratio at all, but I basically ruled out my directional preference, and with the other predisposing factors of the glute musculature, control, and strength, and then also the deep core musculature, control, endurance, and strength, felt like that was the direction I needed to go. For the historical, asterisk sign is not something I could ask him about every time, but I want him to play football and baseball again. And then physical exam, I'm going to continually look at the bird dog, see if he's able to extend that hip and control that hip extension without having to control it through his lumbar spine. He's able to stay stable there, no increase in lordosis. I do expect him to compete as a football and baseball player again. I do not expect him to be back squatting over 200 pounds again. I couldn't find any research to back these up. I was hoping to find something that had studied adolescent males or any males that had grade 2 unilateral spondylolisthesis who's going back to playing football. I wasn't able to find that. People seem to expect that he is able to do that, and I have no reason to keep him out of that specifically, except there's obviously that risk of reoccurrence of injury, but we're just going to have to hope that does not happen. And then I don't want to put him in a position where he's stressing that, where I feel like there's that axial load, no matter how strong we are elsewhere. I don't want to be loading the vertebrae in a manner that heavy where there is a defect. I think it'll take about 2 times a week for 8 weeks. The reason I'm going 8 weeks is because after that, most of the gains are going to be hypertrophy. This first 8 weeks will be neurological. Once it's hypertrophy, he can basically do those on his own. He'll be able to have an HEP, and he'll be able to really focus on working on that glute strength. I'll know he's ready for discharge when he's achieved his goals, or at least able to be independent with his HEP to finish up any goals that he hasn't achieved. Figure I'll stop treatment if there's any increase in back pain. If he starts having those symptoms again, that's not a good thing, or if there are any neurological findings, I sure wouldn't expect either of those, but if those occurred, I don't think it'd be appropriate for treatment. My overall management strategy, I'm going to be focused on glute strength and hip control, and then deep core musculature control strength and endurance. My patient-specific goals, he wants to be able to play 7-on-7 football in May. They're not going to be hitting. It'll just be non-contact type stuff, so I don't see any reason why I shouldn't be able to do that. I want him to return to full activity with weightlifting modifications, which I did give him later on in care. I want him to be able to perform all those 3 motor control things correctly. The bird dogs, obviously, I don't want him to have any increased lumbar extension when he raises his leg during the hip extension phase of that. Side plank, I want him to be on one hand and one foot, with the opposite foot and the opposite hand in the air. We'll hold that with his upper body perpendicular for 25 seconds. I think that'll give him really good control and really good endurance. And I want him to perform a bridge in the manner that I described earlier for 70 seconds with no transverse plane hip movement. And I want him to have a 5 out of 5 bilateral hip abduction and hip extension strength on its manual muscle test. If there are any questions, ask me on the boards, or I look forward to hearing your questions on Thursday.